Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. Pancreatic cancer accounts for about 3% of all cancers in the United States and about 8% of cancer deaths. But for the first time in a long while, a series of potential advances is giving doctors and patients encouragement. Here to tell us about them is Dr. Thomas VanderMeer, Chief of Surgery at the Upstate Cancer Center, where he specializes in hepatobiliary and pancreatic surgery. Welcome back to The Informed Patient, Dr. VanderMeer.
Thank you, Amber.
Compared with the incidence of other cancers, the incidence of pancreatic cancer has edged up. Why is that?
That's probably related to some risk factors like obesity. I think obesity is a big driver for pancreatic cancer. And then some of the other modifiable risk factors like smoking. Smoking does increase the risk, but it's not as strong an association as it is with, say, lung cancer, where we've seen a lot of reduction in lung cancer incidence with the reduction in smoking.
What have been the challenges in caring for people with pancreatic cancer?
Unlike a lot of other cancers where some gains have been made in either prevention or screening or in advances in treatment and even in the translational research that kind of compounds the benefits of the treatment advances. Pancreatic cancer doesn't really have any areas to improve on with prevention or screening, and treatment advances have been really held up because the immunotherapy advances that have been so great for other cancers don't work in pancreatic cancer because it's kind of an immune silent cancer. And then it's also driven by a mutation called KRAS that has been very difficult for drugs to be developed against. But there has been some recent improvements in that. I think we'll probably talk about that a little bit. But those have been the kind of main challenges to improving treatment.
And isn't it a cancer that's hard to detect to begin with in terms of symptoms showing up? By the time symptoms show up, it's more advanced?
Yeah. The majority of cases of pancreatic cancer already have metastatic disease at the time of diagnosis, and it just does grow generally pretty silently. And so it doesn't draw attention to itself the way a lot of other cancers do.
Well, let's talk about what is being done to improve pancreas cancer survival. Starting with surgery, what advances are helping?
So the gains that have been made in the past 20 years have been really pretty much limited to patients who are able to go on and have surgery. And there's a few reasons for that. But we've also been able to operate on more people with pancreatic cancer. As far as the technical aspects of surgery are concerned, as techniques have advanced, patients who were once considered inoperable, we are routinely operating on now. So, for example, there's a large vein that takes blood to the liver that runs through the pancreas. And so that vein is frequently involved very early in the growth of these tumors. And 20 years ago, if that vein was involved, a lot of surgery just wouldn't happen because people weren't comfortable removing and reconstructing that vein, and now that's become pretty routine. So advances like that have just widened the number of people that we're considering operable. The other thing that's happened is that our surgical outcome have improved quite a bit for a bunch of reasons, starting with getting people healthier before they go into surgery, developing pathways and best practices and things like that. So we've improved the outcomes, and that means that more people can go on to get postoperative chemotherapy, which if people are able to get post-op chemo, then that doubles the survival. So as we improve outcomes from the surgery, that has a pretty serious effect on improving oncologic outcomes as well.
What should we know about surgical safety?
The surgery for pancreatic cancer is generally pretty complicated. The complications are common, and so a lot of the advances we've made have been in how we deal with the complications, how we detect them early, the teams that are put together that are familiar with the management of the complications, so that when the complications occur, they don't have such a serious impact on the overall outcome. That's the main driver. We call that failure to rescue. And we've seen that across surgical safety in all fields, where it's not the avoidance of complications that drives high quality outcomes. It's the ability of the institution to identify patients before it starts to have a lot of physiologic effects on patients.
Why is it important for patients to seek a high volume center for their care?
I think that ties into this whole concept of failure to rescue. If there's lots and lots of pancreatic surgery going on, the pathways that we develop to standardize the care that patients get are more adoptable by the whole team. You know, the nurses, the physical therapists, the nutritionist, the gastroenterologist. It takes a whole team, and those teams get put together more effectively in places where there's a lot of pancreatic surgery happening. And then they also know the complications and what to look out for. So the early identification and management of complications happens more effectively at high volume centers.
And so for Central New Yorkers, Upstate New Yorkers, the Upstate Cancer Center is that high volume center.
Yeah, the definition of a high volume center generally is by national groups that look at surgical safety. It's about 20 pancreatic resections a year, and we do about 60 a year. The other thing that we do, we participate with about 100 other high volume centers of excellence in pancreatic surgery across the country. And we have a dedicated nurse that tracks our outcomes and submits all of our data to a central data bank. And then we get our risk-adjusted benchmark data back. So we know how we compare to other centers around the country. And so if there are some issues where we are maybe having trouble, say, with, I don't know, we're having more cardiac complications than we should, then we know that, and we can dig into that and find out what we need to do to prevent those complications from occurring in the future. So tracking quality and being able to act on it and having really high quality data is something that there's only 100 places in the country that are doing that.
This is Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with Upstate cancer surgeon Dr. Thomas VanderMeer about pancreatic cancer. Since about 2020, there are some marked mortality improvements credited to a specific chemotherapy regimen. What can you tell us about it?
Yeah, so early in my career, we didn't really have effective chemotherapy for pancreatic cancer. And then probably about 20 years ago, there was a couple different combinations that looked like they were going to be effective. And then I think in 2011, the first study came out that showed big improvement in the metastatic setting. So patients with metastatic pancreatic cancer had when given this combination of chemotherapy drugs, the response rate tripled and the survival doubled with treatment with this. So there was a big treatment effect. And then the way these things happen is that if it shows activity in the metastatic setting, then the next thing that we try is see what happens after surgery. And so that, kind of landmark study was published in about 2018 that showed, again, that if this regimen of chemotherapy was given to patients who'd had their cancer resected, it doubled the median survival and doubled the 5-year survival.
How soon after surgery does the chemo begin?
We usually start about 4 to 6 weeks after surgery. What we have learned, though, is that people are struggling with the recovery from the surgery, even if it's delayed by up to 12 weeks, it's still effective.
Are there side effects? And if so, how are those managed?
Yeah, these are pretty strong chemotherapy agents, and about 3/4 of people will have some sort of side effect that has to be managed. That's called grade 3 or 4. adverse events, and it's typically nausea, diarrhea. Neuropathy is common with this, which is kind of tingling in the fingers, and picking up cold things can cause kind of pain. And low white blood cells; those are kind of the most common adverse effects from this chemo. But it's usually manageable, and most people are able to get the full course, which is 12 cycles, 12 treatments. It's about 2 weeks apart. And most people are able to get through that.
So in addition to this chemotherapy regimen that's in use, there's an investigational drug that excited doctors and scientists at the American Society of Clinical Oncology this spring. And I read that in clinical trials, it doubled overall survival, which sounds amazing. What can you tell us about this new or investigational drug?
Oncologists are pretty difficult to impress, and when this data was presented, it got a standing ovation at the oncology meeting, which is really very unusual. And the reason for that is that it's been just so difficult to find agents that are new and effective in this disease. And this was an inhibitor for this KRAS mutation, which is present in at least 3/4 of pancreatic cancer. And the inability to treat this has been a major barrier to advancing treatment in pancreatic cancer. This drug was used as second-line treatment in metastatic pancreas cancer. So in other words, patients who had already failed the standard combination chemotherapy that we were talking about, and those patients really have very, very few effective options. So in that very difficult to treat cohort of patients, this new drug doubled their survival, and it's a very exciting thing. Mostly because metastatic pancreas cancer is so difficult to treat because immune treatments don't really work well in the metastatic setting, and so this is just a major advance, and not just in the treatment, but also in our ability to do other kind of translational research, because without our ability to be able to shut down this mutation, it was hard to kind of learn about other treatments that might be effective. So with this, now we can start to layer other treatments on and have a kind of multimodal approach to treating this disease. So yeah, it's very, very exciting.
Does this investigational drug have a name yet that they're using?
Yeah, it's called daraxonrasib.
Okay, daraxonrasib.
And the company that makes it is also developing or they have developed other drugs that work in different ways and may have even a broader effect. So those are in clinical trials as well.
How soon might this be on the market?
It has expedited pathway for FDA approval. And so I think people are expecting it to be FDA approved, probably early next year.
Neat. And what about side effects for this?
The side effects for this are it's better tolerated. It's mostly related. I think the most common thing is rash and diarrhea and some mild nausea. So you don't get the neuropathy with this that you get with FOLFIRINOX, which is this other combination that's been kind of the workhorse chemotherapy for this disease.
Now, earlier you mentioned KRAS, and I wanted to ask you about KRAS vaccines.
So the KRAS mutation, KRAS is a normal gene that produces a protein that kind of regulates cell growth, and it switches on and off. And when it's working, it helps us, our cells carry out their normal functions. But when it gets mutated, it switches cell growth on. And so that's how it drives cancer development, is the growth just continues and doesn't turn off. And so there's just this constant stimulation of cell growth cascades. And it's pretty central in driving a lot of these cancer pathways. So being able to shut it down is important. And that daraxonrasib actually shuts down this enzyme when it's in its on position. So when it's mutated and it's just constantly on, daraxonrasib is able to stop the cellular growth that's stimulated by that on switch. So that's kind of exciting. But the KRAS vaccines work a little differently, and they have an interesting drug delivery system. They have a fat particle that traffics the vaccine into lymph nodes. So it's bound to this fat particle that then takes the vaccine into lymph nodes where the immune cells, the T cells, where they live, and the proteins that are in the vaccine are similar to the mutant proteins that are made that switch the cell on. And what happens then is that the T cells get trained to recognize these mutant proteins as being foreign, and they multiply, and then they go and they attack any cells that have this mutant protein. And it's been pretty effective in clinical trials. There was just one that was just released, and it did meet its primary endpoint of improving disease-free survival. So in that study, it was for patients who'd had their cancers removed. So this was used after surgery. And they were hoping to see an improvement in disease-free survival. In other words, how long patients live before the cancer comes back. And it didn't meet that endpoint. But then when they looked at it, the groups weren't equivalent in terms of the percentage of patients that had had their cancer completely cleared by surgery. So when they looked at the patients who had successful surgery with clean margins and no residual microscopic disease, when they looked at that subset, the vaccines actually doubled survival. So, even though the way the study was designed, it looked like a negative study, I think there was a silver lining in this. I think we still have, some optimism that's deserved for these KRAS vaccines. And these are off-the-shelf vaccines. There's also some personalized vaccines. There's a clinical trial going on where patients have surgery, their cancer is then sent to BioNTech, which is the firm that made the Pfizer COVID vaccine. And these tumors are used to generate a personalized vaccine that's then given to the patients. And so in some small trials, that was effective for some patients. If patients were responders to it, they had a very, very durable level of protection. But that was only about half of the patients. Half of them didn't respond. The immune cells weren't effective in killing the cancer. But that approach is in a larger study as well. So I think these post-op vaccines are potentially really valuable. They're less interesting for the metastatic setting because once there's that degree of cancer, the microenvironment that the cancer sits in suppresses the immune system, and immune therapies have not been very effective in that setting. So the vaccines seem like there's a reason for optimism for the patients who've had their tumor resected and have kind of minimal level of residual cancer.
It sounds like it's still important that you want to start treating as early as you can. Is there evidence that pancreatic cancer can be treated better if it's caught early before it spreads?
Yeah, there have been some studies that have been published in high-risk patients who qualified for screening. And screening for pancreas cancer is pretty involved. And most of these protocols use an MRI every other year, and then an endoscopic ultrasound, which is requires general anesthesia. People have to undergo an endoscopic procedure and biopsies of things, and so it's a pretty invasive screening technique that we have right now. But when patients are screened that way, we have found that when patients do have cancer, that they're picked up much earlier, and the 5-year survival is probably about 75% in patients whose cancer was detected by screening, because, like you mentioned earlier, it's usually at an advanced stage when it's diagnosed, and so it makes a big difference if we can identify these earlier.
You're listening to Upstate's The Informed Patient podcast. I'm your host, Amber Smith, and my guest is Upstate Cancer Surgeon Dr. Thomas VanderMeer. Our subject is pancreatic cancer advances. What can you tell us about a liquid biopsy for pancreatic cancer?
That's another area that we're pretty excited about. It was an early stage trial that showed that a liquid biopsy, meaning a blood test that can be analyzed to identify pancreatic cancer, was effective in identifying early stage pancreatic cancer in high-risk patients, and it was able to differentiate patients who had pancreatic cancer from those who didn't. So the accuracy of this liquid biopsy was very good. What it does is it looks at, it's called microRNA. RNA is used by cells to signal protein development, and it's released either into the bloodstream as kind of a free just piece of nuclear material, or also in these little packets that the cells make to secrete it. So these investigators at the City of Hope in Los Angeles identified a signature, both exosomes, these little microvesicles, as well as the cell-free microRNA that was very, very accurate. It was a small study that was published. It was about 100 patients with pancreatic cancer and 67 normal controls, but they were able to kind of optimize 13 microRNA signatures that were able to differentiate between early stage pancreas cancer and normal controls. So that's also being validated in a much larger international cohort of patients, and we're hoping to see results from that sometime next year.
Is it thought that it could be a blood test for everyone to take to screen for pancreatic cancer?
I think that the benefit of this is that because it's less invasive, you could broaden your definition of the high-risk cohort. So in the other studies, when you're subjecting everybody to MRIs and endoscopies, the people that we really wanted to have a cohort of patients that had really significant risk, they had some sort of genetic predisposition that put them at very high risk for developing pancreatic cancer. But now if you have a less invasive biopsy like this, I don't know that you'd screen the general population, because that could lead to a lot of unnecessary biopsies and things like that. But there are other groups of patients that are at elevated risk, but probably not high enough to justify, all these invasive tests. So examples of that would be, say somebody develops type 2 diabetes, but they're not obese. That could be an indicator that maybe it's a pancreatic cancer that's driving that. Or patients who have chronic pancreatitis, diseases of the pancreas that cause inflammation will increase the risk of developing pancreatic cancer by about 2 or 3-fold. So, they're not at 20 times the risk of the general population, but they're at elevated risk. And so I think for those patient populations, this could be really helpful.
Now, do the advances we've been talking about apply to bile duct cancers or liver cancers that are also deep in the abdomen?
Each of those cancers has a different type of mutational driver. So these particular advances don't apply specifically to those, but these types of approaches do. Because if we could improve our screening, our early diagnosis, and have more targeted therapies for those cancers, then advances would be made there as well. And I think for bile duct cancer, they have a much different mutational profile, and there are targeted drugs for bile duct cancer. For hepatocellular carcinoma, as well as bile duct cancer, those do tend to respond to immune treatment, and those are currently commonly used to treat those cancers.
Where do you think the field will go from here?
Well, I think for all of these things, we're addressing all the barriers that we talked about earlier that have limited improvement in outcomes in pancreatic cancer. So I think we will get better at screening. I think we will, if it's not this particular tool, then I think that we will have liquid biopsy. There are some pre-malignant tumors that have shown advances in being able to predict which ones of those will go on to develop pancreatic cancer. So the genetic approach will apply to those as well. It'll be a little different than what we talked about, but to be able to remove a pre-malignant cancer when we know that it's at a higher risk, that will move the field forward quite a bit. These treatment advances that we're talking about, especially being able to block KRAS-driven pathways, will lead us to be able to learn more about cancers and what works. And so I think the translational research will much bigger growth area going forward. And so I think that we can look forward to a better understanding of how to prevent and treat pancreatic cancer in the not too distant future. So I think it's a pretty exciting time for the patients and the families that have this disease and will develop it in the future.
How much better is the overall outlook for someone diagnosed with pancreatic cancer today than 10 years ago? Because this used to seem like a certain death sentence.
Yeah, well, I think if you look at survival curves over the last 20 years, people are living much longer with this disease. The advances that have really driven that are due to having effective chemotherapy, broadening the surgical indications, and having safer surgery. But now we're getting to the point where we can detect the cancer earlier. 60% of patients with pancreas cancer present with distant metastases at the time of diagnosis. So if we can detect it earlier, we can really make a big difference. And these treatment advances will, I think, make a big difference as well. But to answer your question maybe more directly, I think the 5-year survival for patients with pancreatic cancer has been improving by about 6% per year over the past 15, 20 years. The reason that the overall mortality statistics haven't improved as much as other cancers is because the incidence is going up. But overall survival for patients who have pancreatic cancer has definitely improved quite a bit. And that's even if you're looking at 5-year survival. If you're looking at 1-year survival, the 1-year survival for patients with pancreas cancer in the year 2000 was only about 22%. So 25 years ago, only 20% of patients diagnosed were alive in a year. Now that's about doubled up to about 40%.
That's very encouraging. Well, Dr. VanderMeer, I want to thank you so much for making time for this interview.
Well, thank you, Amber. It's always great to talk to you. And I'm happy to share my enthusiasm about all these advances. It's really a wonderful thing.
My guest has been Dr. Thomas VanderMeer, Chief of Surgery at the Upstate Cancer Center. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.